This is about the next chapter, the transition from childhood to adulthood. I'm Jenny Burke. I'm Family's SCN2A board chair, and I have a 24-year-old with SCN2A related disorder. And we have a panel of experts here this morning to talk about our experiences, both from the care standpoint and the legal and school, what happens when the bus stops coming standpoint. And we really encourage your questions. So it's going to be not just us standing here talking, but trying to answer your questions. And our esteemed panel here, raise your hand. Dr. Courtney Santucci is pediatrician at Children's Colorado who has experience in complex care and transition. Dr. Philip Zeitler is an endocrinologist at Children's Colorado, but also sees patients well into their 30s. Renee Holmes, mom to Carson. Good morning, Carson. And Anita Morris, mom to Jaylene. Good morning, Jaylene, down there. So we're going to be covering several topics today: bone health, puberty. Back to bone health, some of you may have been in this session yesterday from the nurse practitioner at Children's Colorado. That'll be recorded, so please refer to that later if you need any references. The transition of care process, legal and financial considerations, and post-high school plans. This is being recorded, and all of the slides are going to be on the website. So there are way too many slides for, we're not going to talk through them all today. They're just going to be up there to look at and to refer to later. And I'm going to turn it over to Dr. Santucci for a minute. I'm sorry, Dr. Zeitler for a minute.
Good morning, everybody. One of the issues we thought would be worth talking about was the impact of puberty on many features of the life of kids with neurodevelopmental disabilities. As many of you know, early onset of puberty is quite common in the whole range of neurodevelopmental disabilities. And so this often has an impact. Let me go back. From what I can tell, there is not a direct relationship between SCN2A and puberty. However, puberty has an impact on everyone's life, and it definitely has an impact on those who are living with neurodevelopmental disabilities. And what we want to do is answer your questions around puberty that may come up. And some of the questions that we thought were important and for you to think about before we get to the questions at the end are such things as, what are the likely effects of puberty on growth, bone health, and behavioral development in my child? What are the pros and cons of intervening for delayed puberty if this occurs, which is less common? What are the pros and cons of intervening for early or precocious puberty if this occurs? What specific factors put my child at risk for bone health concerns? What can we do to minimize these factors? And what treatments are available for osteoporosis in individuals like my child? And when is the recommended time to start them? But the most important thing is to be sure that when you speak to your doctor, you're sure that they are thinking about your child and the specific aspects of your child's life. Because again, there is not a direct relationship between SCN2A and puberty. However, puberty has an enormous impact in everyone's life, but it's an individual impact. And so we will come back to these questions at the end of the session.
Thank you. There's supposed to be an and sign between puberty and bone health. Now I'm going to ask Dr. Santucci to talk about the transition of care. There's 2 slides.
Okay. Hi, everyone. Thanks for being here this morning. I'm Courtney Santucci. I'm from the Special Care Clinic at Children's Hospital Colorado, where we take care of kids with medical complexity. So for me, SCN2A, number one, I want to say I recognize that there's a broad span and spectrum of how SCN2A changes might impact on kids. But generally, we're talking about a diagnosis where we can expect complex neurological symptoms and need close involvement with our neurologists from a very young age, and I'm sure all of you know that. So when it comes to this topic of what happens when my child becomes an adult, and of course legally that happens at age 18, what I would first say is let us not be afraid. Others have gone through this adult transition of healthcare process before your family, and there's a lot of information, kind of a lot of guidance, and a lot of deep knowledge that comes from this community, and I would just say we tap into that knowledge, we use all the resources that have been developed, and we go through calmly through this very scary transition process. In a nutshell, our children are going to transition from a pediatric model of healthcare, which I think can feel a little more holistic, a little more ready to meet the child where they are in their needs, over to an adult model of healthcare delivery, which is maybe more challenging to navigate. And despite those challenges, it is possible. So my bottom line advice on this process, and we will go through a lot of case examples of families who have done this and explain what specific resources exist. But my bottom line advice is to think about this upcoming adult transition process as early as you can wrap your brain around it. Ideally, that starts in the mid-teens, and to use resources to organize yourself and organize the things that we know your child will need in adulthood, and explore who those adult providers in your area could likely be, and just begin making some connections and making some plans early on in the process before some of the more legal needs, like going through the guardianship process and changing over to adult insurance, also add into the mix. So if we can sort of break this apart a little bit into there is the healthcare system and what we will need from it, and then the community-based supports and insurance systems, and sort of bucket those a little bit, I think things can go reasonably smoothly. But it's a heck of a ton of work, and I appreciate that. And we as your providers, I would say, no matter where you live in the country, we're ready to help and just guide your family through this. The bottom of this slide, and I understand these slides will be shared, so you can't click that bottom link right now, but when you're at home later or years into the future, you can come back to this. There's a wealth of information that's clicked through by clicking that link to resources from like the Childhood Epilepsy Foundation, SCN2A Foundation, of course. The Courageous Parents Network also has a wonderful sort of module for adult transition, which includes videos, documents, website links, like you name it. It's just deep in how much resource it gives. And so it really just takes the time to look through it all. But the resources, I would say, are there. And just to dig in a little bit more to those adult versus pediatric resources, I think the hardest thing here is that your pediatric team knows your kid, right? And you know them, and you know how to navigate calling the doctor's office, getting in for urgent visits when they're needed, how to get to the emergency room. All those things will be known in the adult realm to you once we make this transition. I think the scary bit is just crossing that bridge and making that leap. And so I would say neurologists around the country have generally embraced a model of adult transition where there may be in your area something like an adult transition clinic where your pediatric neurologist and your adult neurologist have a chance to actually communicate in some way, shape, or form, whether that's being in a visit together or at least having a kind of a warm handoff of information. And so I would say don't be afraid of that process. Adult neurologists are there to take over from your pediatric neurologist. We just need to make sure that we leave time for that warm handoff to occur. Again, more resources for you to look at after the fact are on the slide. Okay, I'll stop there to keep it brief. Okay.
Just a reminder, please write your questions on the paper on the table, and then we'll take them up in a few minutes. We'll start taking them. Now we're going to have each of the parents just tell you what we've done in our situation. We've all done something a little bit different, and it just goes to show that there's not one answer to how to transition, and it really does depend on your child and their needs and the resources available in your community. So I'll start with Alex. He is 24. We got full guardianship at 18, which is normal, but you may not need full guardianship, as you'll see. He's got the supplemental security income from Social Security. That was a process. Medicaid in Virginia changed when he graduated from high school. He was able to get a higher level of services. But that, again, that was a long process. We were on the waiting list his entire life for that. He graduated, he was aged out of school at 22, which is fairly common, but might be earlier in some states. Unfortunately, there's a picture of Alex with his lovely transition teacher, who is actually a friend of mine, and she was fantastic, but there was nowhere to transition to when he graduated. So just now, 2 years later, he's finally started a local day program that can handle his medical complexity. Just 2 days a week, which is fine. That's all we need. And we do have an aide that comes to the house through our Medicaid waiver. And we'll stay overnight sometimes when we want to travel, which is really fortunate. I am in complete denial about leaving pediatric care, so I'm probably not the one to talk to about that transition. All new specialists we've had to get in the last couple of years are adults, and they've been fine, but I'm hanging on to the last possible moment with the gastroenterologist, neurologist, and primary care. And we have a special needs trust, which is how you've got to protect their they can't have any income in order to get government benefits. So that's just been our plan. That if something happens to myself and my husband, our life insurance would fund that trust, and we have a trustee that would take care of Alex. And next, some of those pictures are things he likes to do. Bowling, the beach, golf tournament in Buffalo. And I don't know if he likes being in the standard, but it's really good for his bone health, so he does that every day too. So I'm going to pass it off to Carson's mom. Renee.
Hello, I am excited to visit with you all a little bit about what we've done with Carson over the years. We didn't know of Carson's SCN2A diagnosis until he was 18. And so the first slide, it just gives you a little bit of background on Carson. Most of y'all know Carson is Carson that gets to come here every year and visit with everybody and hang out at the bar. But when Carson was younger, he came into the world in great Carson fashion with a ruptured umbilical cord and a no anesthesia C-section, and told everybody he was here. But Carson didn't truly start communicating verbally till he was about 19. He used Proloquo to go and Proloquo for text for many years. At about 15, we realized he could text, and so we switched over to the Proloquo for text. And so we just wanted to give you all a little bit of background on his diagnosis. That's kind of our running diagnosis list. Those last few have actually come into place since we started attending the conferences. I didn't know we really needed to be looking at his bones so hard because we didn't know we had a diagnosis, honestly. And so he has an osteoporosis diagnosis, a CVI diagnosis, and in the last year was diagnosed with Wolff-Parkinson-White syndrome, which is a cardiac condition. So our life is, every day is interesting at our house. I'll just promise you that. And we really started transition planning with Carson when he was about 10, and he has a sister that's a few years older and with some complex medical conditions, and so we were working on hers, and I'm thinking, we're going to have to figure out a way because he's going to grow up too. They're growing up, and what are we going to do next? That was kind of our thought. So we really started working on that communication piece and started really encouraging him to use his device at that point. He mainly only used it to tell us what he wanted, and usually it was chips or video games or a movie. And but that was something. So we kind of started with that and moved on from those pieces, but we still had lots and lots of seizures, and so every time we would have a big cluster of seizures. Everything we had just started working on and worked so hard to gain, we lost. And we kind of explained it as it was a whiteboard. My best friend explains it as the Etch-a-Sketch that you shake up, and it's all just jumbled up again. But we would always say everything he learned, it was like you wiped it off with the whiteboard. And we would work really hard and get those back. But as we started those early transition training in years, we worked a lot with our state's Protection and Advocacy Center, our state's PTI, which is the Parent Training Institute, and I'd worked a lot with our state's Title V agency, and I just wrote them a grant for transition, partnering with Got Transition, which is a national transition resource clearinghouse. And so we used a lot of those things as we were early on in those transition years. We moved from the biggest district in Arkansas, biggest school district in Arkansas, to probably one of the smallest when Carson transitioned to high school. And that was the best thing we could have done for him because he needed that smaller setting and a smaller situation. One of the things we learned really fast is that one, they included him in everything. Carson was just part of their school, and he was Carson. And all the girls loved Carson. Like you can see, this was every year they would, and Carson never really thought to tell us, hey, I'm in homecoming until the day of homecoming. And the school would call and say, Carson doesn't have his suit. And I would call the house and call Kendra and say, somebody go to the house and bring him his suit because he's got something going on. But what we also realized is that all that puberty stuff that we just kind of skimmed over, we had to pull back out. And I remember Matt called one day, he goes, I need you to get that book. And the book was, we used the Kennedy Vanderbilt Center's Got Healthy Bodies curriculum a lot. And I had made Matt help me put it together for a training. And he goes, I need you to get that book out. And I'm like, I don't know what you're talking about, that book. That's what he was talking about. So we pulled it back out and really worked on those things of who you can handshake, who you can hug, and who you can high five. That's my favorite out of that. Because, you know, and if you don't have those discussions about consent, Carson is a people pleaser and everything is yes. And if you never learn to talk to say no, how can you ever tell anybody no for anything? And so pulling those things back out and having those really hard conversations that weren't on my bingo card, because I didn't think I needed to do that, was a big deal at our house. So those are those high school years, and I just really wanted to bring that up. And things that you may not think you have to talk about now may jump out at some point and go, hey, all the girls are loving us, and we are not sure what to do with that. So really having those hard discussions, and I really love that curriculum. I've got a link there. They have it set up for different age and developmental groups, maybe is the best way to say that. And so I usually put it in like paper protectors because there's some things you might not want to talk about. There's some things I don't want to talk about, but sometimes you need to. And you can pull those out in little bites and little chunks and have those discussions. But Carson, let's see. Let's change my slide. There we go. Carson was encouraged by his school to walk with his graduating class whenever he was 18. However, he stayed in high school until he was almost 22. And that year before he turned 18, the school looked at us, this very sweet transition teacher who we absolutely adored, looked at me and said, well, who's going to be Carson's guardian? And I looked at her and I kind of got a little nervous. And I said, Carson's going to be his own guardian. And I didn't know what in the world, how we were going to manage that at that point and how that was going to work and what that was going to look like. And they looked at me and I looked at them and we just kind of went, okay. And we did it. But that was a big thing for us that year. So in that realm of guardianship, Carson is his own guardian. We have a supported decision-making plan that we set up. Our state actually, our legislation voted down the state's plan for a supported decision-making act, but I worked with our P&A at that point, and we developed one that worked for us. We've written social stories about making decisions and how everybody has to make decisions, and I surely didn't make the best decisions at 18 years old. I'm the mom of a 26-year-old, and she didn't make all the best decisions at 18 years old, but none of us do. And so I thought, well, you know what? He's going to have better support than any of us had at those ages to learn how to make those decisions. So that's what we kind of jumped in and did. He did stay in high school through as long as they would, until they made us leave, essentially. But early on in those high school years, in those years that y'all didn't know Carson, we had really heavy supports. We were doing lots of things. He couldn't really have off-campus job in their job training program because he just seized all the time. As we got some seizure control, they started moving those jobs outside into the community. And so his favorite job was working at the library. The day he graduated out of that 21-ish-year-old age group, he brings home this little gift from the library lady with a note that says, "Please have your mom call me." And so I called Miss Jennifer at the library, who says, "We want Carson to come back." And so he works at the library every week still in this little tiny town next to our town. He goes to work at the library. Our medical piece of the transition, when we moved to this new little tiny town, there were no pediatricians in this little tiny town, which probably worked out better for us because we at that point transitioned to adult services for primary care. And so we did that transition then. We travel out of state to see neurology because they just look at us like I'm not sure what to think. We haven't found a GI doctor yet. Kendra found a good GI doctor, so I think we're going to work our way over there to see hers. But that's been a big key. We got a CVI diagnosis in those last few years of high school. And so the OT that we used in school worked really heavily with our State School of the Blind. And he's now seeing us privately and actually sees us and does Carson's occupational therapy at the library with us. And so they work on shelving books and they work on all those jobs that he has there because that's what he needs, honestly. I can't read my last slides. Oh, our Medicaid piece. Carson had Tefra Medicaid until he was 18, and then at that point we transitioned over to adult SSI. I'm his payee, even though I'm not his guardian. And that's something that you can work through with Social Security. He's on our state's home and community-based services waiver. In Arkansas, that was a 10-year, 5-month, and 28-day wait. So if you are not on your state's waiver wait list and it has a wait list, go do that. I will help you. I will find you the people that you need to talk to do that. But we are on waiver. He has 3 paid staff, and they get to do all the fun things with him. And he is not stuck hanging out with mom because I'm not cool. Let's see what else I have up there. We do have an ABLE account. He has his own bank account that has maybe, I think, a whopping 88 cents in it. And that's one of those decision-making things you get to learn. When you run out of money, you don't get to go to the bookstore. So he does have his own small account, and then we have an ABLE account that we stash our money that we're saving for him in. But that's Carson's story. And everybody's story looks different. So please don't think what one family's doing is what every family does. Okay, Miss Jalene's story.
Are you doing the slides or am I? Just do green? Okay. Sorry. Okay, so Jalene's story is a little bit different than Carson's. So her diagnosis through the years, she started out with severe GERD. She was hospitalized the first time at 3 weeks of age. And I thought about that yesterday when somebody was sharing their story in the morning. She spent her first year of life basically in the hospital more than at home, mostly due to her GI issues. She started being tube fed by 3 months. So she was failure to thrive. She got an early diagnosis of autism. She was diagnosed officially by 12 months. Nonverbal, global developmental delay, intellectual delay, slow gastric emptying, intestinal malrotation, intractable epilepsy, LGS, cerebral palsy. Oh, I've got it on there. Complete gastroparesis, where she then went on TPN for 5 years. And then last year she was diagnosed with the the CVI. Okay. All right, so for us, the transition, they started talking to us about it about age 15. It started with the school and in that IEP process, and they were looking at what is she going to do in the future. But she was also at that time in a major regression. So the things that we originally thought she might be able to do, it was changing. She was no longer able to stand, maybe help with some of the cafeteria stuff they would have them doing. All that kind of stopped. She was in a chair for most of the time. So those things were changing, and we were trying to figure it out. And we were looking at communication devices, but through the years, we started with PECs and then Proloquo Go, and the school had different devices they were trying with her, and she just never really had an interest in reciprocal communication back and forth. So her pediatric hospital had started a transition clinic, but it still didn't have any doctors attached to it. So when I listened to some of the families where there's things already in place, we were kind of at the beginning of that wave. And so things were just starting to be seen as a need and maybe starting, so it wasn't quite there yet. So that's could be partly why ours was a little bit different in the transition, but we did have a brand new transition clinic set up at our hospital, and they would contact me occasionally to say, have you found someone for this or for that? Because they were looking for people to add to their resource list. It took a long time to fully transition for her because she was in kind of a fragile state medically, mostly due to the TPN. So we needed a good GI, and we also needed a really good neuro because of her seizure disorder. And neither one of those were we able to find easily in the adult community where we're at. So it took quite a while. It took until she was, I think I put on there 24, so she was a couple years past, and it really became to the hospital was saying, that's it, these providers can no longer treat her because they had too many of their own kids. So we ended up finding a wonderful neurologist, and our GI doctor is getting better at it. He's not had anyone like her, so kudos to him that he's really trying. For legal, Jaylene went under a conservatorship, a full conservatorship, and I have extra medical consent powers. In our state, some states guardianship, our state was a conservatorship, and even with a full conservatorship, I couldn't give permission for a surgery if she needed it. Sorry, guys. I think that's my phone down there, yeah. Without medical consent powers. So I have a full conservatorship. She's not able to make those decisions. If she is processing it, she doesn't really have a way to put it out to you that she's processing it and this is what she's interested in doing. So for us, that was required. And we do have a program like what they were talking about for this within our state that a lot of people are able to then choose not to go that direction and just have the supportive services. Our regional center was not real helpful for us in the process. Again, they just didn't have access to resources, and in some cases, I'm surprised they didn't really have the knowledge of what was out there. They could really only help with the programs that they were offering, like they said, a day program. She transitioned out of the school programs during COVID. I think I have that on the next one. So she transitioned out during COVID. So her last year of the adult transition program was during COVID, and I thought, we did it online, but I think she really did get some things out of it, so it was a good thing. But the day programs weren't open, and by the time they were, we'd already put a program together at home, and she was on TPN, and it did require them to have an RN, so it was just easier to keep her at home. She is on SSA now. That is a change just this year. She was on SSI, but her dad had retired and started collecting his Social Security, and after 2 years, your child's no longer allowed to be on SSI. They have to go to SSA. And so that is a new thing that we're just learning about, and in 2 years, she'll transition to Medi-Cal. Is that what? No, Medicare. She'll transition to Medicare. And then, depending on her income, she may have Medi-Cal as well. But it's interesting to watch that transition at this age, things that happen when you're closer to 67 or whatever. So let's see. Today she is in a really good place medically. So this year, started last year, I think. I've just started to make this, let's hit those things on the bucket list. So we've been doing a lot of traveling. She's happy. She's very stable in her health. We've this year gone to Hawaii, Disneyland, and now Colorado. She flies very well, so I'm grateful for that. Her mom a little less so, but let's see. Yeah, I think that's it.
Thank you, everybody, for sharing. Don't let these slides seem too daunting. We've divided it up by the age you should start thinking about things on the transition timeline. Really, this is more for later when you want to go back and see, I'm this old, what do I need to be doing? But start early is the message. You can't start too early thinking about it and talking to people. And really, the most important people to talk to are other parents who are in your local area and other parents in our SCN2A community who've been there before that can point you in the right direction, or just have someone to talk to or vent when you can't find an adult gastroenterologist or dentist. There needs to be a sea change, I think, in our healthcare system with this transition of rare patients, but we're not quite there yet. Most of these, everything on this timeline are more about the legal and post-school issues. I'm just going to go through them fairly quickly. There are different ways to protect the child's income, special needs trust or ABLE account. Income is the wrong word, but any funds that they might have to make sure they can still get government benefits. Renee is the person to talk to about that. And Anita. Legal adulthood is at 18, so you really have to apply for SSI by then. We tried to apply early, even for guardianship early. You have to have guardianship before you can apply for SSI, and it took so long that we were well into his 18th year before we actually got all that done. And then what are you going to do after high school, after the bus stops coming? There are many, many options. You just need to start thinking about it and talking to your child if your child can talk. Mine cannot, but if they have wishes, work on that, and then it goes well into adulthood and beyond. So if you have questions, write them down, or we can also bring microphones around. Direct them to anybody in particular here or just in general, and I'll read them. Mara's going to bring up the ones she's got so far. And then I'm going to just leave the top tips there.
I don't know, is my mic on? Can y'all hear me? Okay. One thing I did want to say on that timeline, it's such an important thing to see and to look at and to work through. And we say it all of the time, start early, start early, start early. If you are looking at that and you're going, oh gosh, but my child's 16 or 18 or 22 or 24, also don't think it's too late to start. Jump in, swim and catch up to the ship wherever you're supposed to be at, but just get in there and get your feet wet and get started. Don't feel like we're past that, there's nothing else that we can do. Get in and ask those questions. Somebody will help you catch up.
Okay, adult transition clinic question, maybe for doctors. What would that look like? Who's involved or who should be involved? This question may have come from a clinician, I'm not sure.
Cool. There are different ways of doing this, and so across the country, depending on where you live, the system may be set up a little bit differently, but I'll give you the example of where I work, and then maybe one other example of how I know it works in another place. But so in our city here in Denver, we have a big children's hospital, and we have a big university hospital, University of Colorado, which is for adult care. Fortunately, they sit pretty much on the same parking lot, and so physically they're very close to one another. And we even sort of share the electronic medical records so that we can see the notes from each other pretty easily. And I'd say that, no matter where you are, that's a desirable feature. So if the adult providers who will be taking over your child's care for neurology or GI or orthopedics, dentistry, you name it, if they can see the thinking, kind of the notes and the medication history reasonably readily, I think that's a great feature. So in our city, when kids get close to 18 and have intellectual disability of any degree, we consider them candidates for our Adults in Special Care program, which is sort of an ongoing primary care based out of the Children's Hospital, but their specialty care moves over into the adult realm. And then each division, so whether it's neurology or GI or orthopedics, each division has a little bit different situation, but in neurology, for example, it's actually very nice. There can be sort of co-treat visits where the pediatric and the adult neurologist have a time and a space to review, say, the most recent year's history of seizure control, which medicines have worked or not, and what all kind of needs handing over. We have a transition hub, we call it. It's the impact team based out of the Children's Hospital, but they really act as shepherds for that transition until the young adults have transitioned all of their specialty services over into the adult realm, and the family goes, we're good. So that's one way that it could look. Is that the primary care could be sort of a medically complex focused adult clinic, whether based in a children's or an adult center, and the specialties all kind of moving over gradually. I usually do try to remind families that this is not necessarily like a light switch turning off, right? Like,
It's several flipping of light switches sometimes, I think.
Yeah. Any given specialty group may have sort of a different age after which they don't feel comfortable to continue refilling prescriptions or seeing your child for visits. They should give you plenty of notice about what that age is, whether it's 19 or 21 or 25 for the pediatric providers. But you may see that not everything changes over right at 18 or doesn't need to. That said, I think the sooner the better, to just not be put into a situation where you are up against sort of a specialty's deadline where they're like, well, we can't do that anymore for you. And you don't have time to make those first appointments in the adult realm and have some kind of cross-talk and cross-coverage. That's why I say aim for 18, but things may sort of linger a little bit on into 19, 20, 21 even.
And as a parent, when that provider brings up we don't see children here after the age of X, as hard as you want to bury your head in the sand and pretend that that's 3 years down the road or 5 years down the road, don't. And I mean, it was so easy for me just to go, I'm not going to worry about that. If it's too far out, don't do that. That's my mom's soapbox.
No, I completely agree. This goes well when everybody is sort of thinking more proactively about it and not thinking about that age line as like we don't have to worry about it until 19. That's like a deadline. Like,
that's
right.
The line.
We need to be on the other side of the bridge by the time we turn 19, and to try to not fear it so that you have time to build a good care plan for each specialty area of need, and meet those new providers before your services cut off in the pediatric realm.
Yeah.
Dennis has a question. Yeah.
No, I just want to give a brief comment how we approach it as the other SCN2A clinic. So in Houston, there is no difference between adult and pediatrics. So because the clinic is led by me and my counselors serve pediatrics and adult, and the adult epileptologist and the pediatric epileptologist, they are briefed by us. So if someone would transition because of age, we would make sure that the pediatric neurologist would meet with the adult neurologist, because we have anyways prep meetings, at least 2 or 3 before a patient comes in. And there would be all this guidance happening before. And a lot of the prep is done by the residents, which the residents serve the adult and pediatric providers to enhance them. And the genetic counselors, for example, they serve also pediatric and adult. So the counselor would never leave. The counselor would be a part of the pediatric and adult transition just naturally. Same with some other things. It's a little bit unusual, but because also the pediatric clinic is 1 floor below the adult department.
Convenient.
So it's a little bit different.
Thank you, Dennis. It's so there's no one program, but it's,
Maybe the last thing to say is, like, no matter where you live, I think a helpful exercise in the mid to late teens is to make a list of who do you need for your child. Like, who are you needing to call on for visits, prescriptions, orders for medical equipment, et cetera. Who have you needed? You're probably going to need those same kinds of people in the adult realm, and it may look a little different. They might not all be under one roof or under one hospital, system in the adult realm, but you at least know who you're going to need, and you can start to build your your to-do list from there.
I just wanted to add that I'm in an area that didn't have the perfect transition that you put, but was put together, and I'm hoping that maybe they share that with other transition teams across the country as they start to build those things. But for me, the best resource was other parents who were a few years ahead of me, because I couldn't get it from the agencies, I couldn't get it from the doctors. I started talking to my friends. That's how I was able to start finding the next provider. And it took a while. Some of them didn't, want to necessarily open their doors up because they knew that it would be maybe a floodgate. But for me, the best thing was talking to other parents. Where are you taking your kid for this?
Thank you. We have quite a few questions here that run the gamut, so I'm going to move on. If supported decision-making is the choice, how does applying for government benefits work versus guardianship? Is there a difference, Renee?
In our situation with our supported decision-making plan, we set it up that we have, on Carson's supported decision-making team, it's myself, Matt, and Kendra, who is his sister, who's 26. I had to think of the math for a minute there. So we all three have power of attorney and at one point he had educational power of attorney as well because he was still in school. But we have medical and financial power of attorney. We have a separate, we did additional paperwork through the Social Security Administration so I can talk to Social Security for him. It took us about 2 minutes on the phone with the Social Security office, and they said, "Can we just talk to your mom?" And he said, "Yes," and he took off. And so we were able to do that. We've been able to work with our bank with him. We were able to call the bank, go to the bank with him, and help represent him there and help answer and ask those questions. The place that he got really great at signing consents for himself was when we started in a drug study. And that first few visits, there's about 40 pages of sign and date and initial and sign and date and initial and sign and date and initial. And we just booked about 2 extra hours, and so we could work through all of those, and they worked through and did a great job at helping explain those things to him as well. And we knew that anytime he said no and we were done, even though we really wanted to do that, but he was able to see the benefit that was coming out of that as well. So it took a little bit of work. And like I said, our state legislation had just voted down a bill. And I remember sitting in the chamber the day they ran that bill, and somebody on our state legislature who's a parent of a child with a disability stood up and said, "Do we want those people to vote?" And I about had to get arrested, but that was kind of how that went. And that's one of the things, as you look, and states are different. Each state has different legislation of what somebody that has a guardian can and can't do. And that was a big deal for Carson. Carson is the best. He's probably the more informed voter in our house than anybody else because he has pulled the sample ballots and we've read it and we have to go through and explain all those things and what everything means. And he makes those decisions better than I do.
That's great. Yeah, that was one of the, in Virginia, where we live, there were a few options with guardianship. You could retain your right to vote if you chose to. Alex is nonverbal and doesn't have the capacity to do that, so he does not vote. But I'm glad you're voting, Carson. A few more questions for the doctors and for girl moms. If you have a female, what steps should we take regarding the risk of pregnancy?
This actually might be a better question for Dr. Santucci. What? Sorry? Yeah, okay, I'll do me and she does her. There are obviously very many options. for both contraception and menstrual management. Also, some families are interested in regulating periods so that their sort of hygiene and nursing care is easier. There are a variety of ways to do that. You can do that with progesterone, Depo-Provera. You can do that with continuously taken combination oral contraceptives or patches. Something that we've moved to more recently has been IUDs. Although it's daunting to think about that initial insertion under anesthesia, in the long run, menstrual regulation as well as pregnancy prevention is probably the simplest with IUD.
Yep. And I would say, 10, 15 years ago, my answer would have been Depo or the pill. And now my first go-to answer is usually a Mirena IUD. And I think it's just really nice to get at least 7 or 8 years at a time of not having to take a shot or take a pill or crush something or change a patch every week. It's just works really well.
And also not have the systemic hormone effects, which is very nice feature.
Great, thank you so much. Does anyone have experience with having seizures while on a flight? And how does the airline going to react to that? They obviously aren't probably comfortable with that happening. What are your thoughts?
So, yeah, just on a personal note, when she was younger and we were flying across the country, she did have not a tonic-clonic. So she was having some small seizures, and I was able to just use the magnet. And
She has VNS.
yeah, she had her VNS by then. So I was able to use the magnet. And then also I did do a lorazepam, but I don't know what they call them now, stewardesses, flight attendants. Okay, flight attendants. They didn't even notice. They didn't know what was going on.
I think it depends a lot on how big of a seizure, how long of a seizure, and whether the things that you have in your travel bag can be enough, or whether you really need something like suction or supplemental oxygen or the plane to land before you get to your destination. So I think it can be really scary when families who have a child with epilepsy travel by air. If the seizures are pretty well controlled generally and usually stop on their own or with a quick dose of like nasal, for example, rescue medication, I don't discourage families from traveling by air. I think the other thing to consider, though, is the behavioral aspects of seizure and the postictal phase, and just how might that look on a plane. You just have to think it through. How long's that flight? What meds do you have at your disposal? Is it worth it just to drive? But yeah, I mean, seizures don't necessarily land a plane early. And I would say flight crews, I've heard wonderful examples from families of flight crews being incredibly helpful and compassionate and good humans. And I've heard other examples of flight crews being not helpful and not nice people about it. So I think that can really go either way, and it's very human dependent.
Right. I don't know. I haven't had any experience with TSA Cares, but would doing that program beforehand be helpful, or are they going to say, don't fly?
It just helps with the airport. Yeah, go ahead. So TSA Cares will help you with the airport, but I always call my airline as well. Long before the flight, let them know about her, let them know what we were going to be bringing, and if they have any special rules about it, what are they going to need from me before we board. And then I let the flight attendant know as we're entering, this is what I'm going to, because there's things you have to stow, and there's things that it's like, this is not going to be stowed, and where's the best place that we can keep it to meet regulation, but also to have it right there if we need it.
That's what I was going to say. Just the logistics of where I keep stuff on the plane, that I'm not having to get up and get meds out of an overhead, and that backpack that's ugly and giant. Usually everything is in that front pocket that I would need to make sure we have. And even with local day trips. Like Kendra took him, they went on a no parents trip. And that was when I'm like, make sure, here's the nasal rescue meds, and you make sure to keep them with, just having those kind of conversations, make sure you can get to them so that they're not, in the car 2 miles away while you're at this wedding. Make sure you have them in your purse.
Great, thank you. All right, this one's definitely for you, Dr. Zeitler. My daughter went through precocious puberty, started at age 6, began menstruation age 9, stopped growing around 10, now 19. When should I be concerned about osteoporosis?
That's a really good question. Any individual who does not have a typical relationship between muscle and bone is at risk for osteoporosis. And that is actually true beginning in early childhood. Unlike in most individuals, osteoporosis is a risk early on, prior to puberty, prior to menopause, and that's because the etiology, the source of that osteoporosis, has to do with the decreased pull, if you will, of the muscle on bone. So much like astronauts, when there's no demand on the muscles and bones, the bones are designed to become weaker. There's nothing promoting them to stay strong. So there's actually no magic age at which an individual with a muscular problem suddenly becomes at risk for osteoporosis. It's true from early on. The tougher question is what to do about it. And historically, we have waited until fracturing is occurring before intervening. This is not something we do based on bone density necessarily, for a variety of reasons. Once fracturing starts, then that is a concern for the presence of osteoporosis. So I would basically say the answer to that question is there is no age at which to worry about osteoporosis. It's always a risk. You should be doing what you can conservatively, promoting as much physical activity and weight bearing as possible. Make sure there's enough vitamin D, calcium, and a healthy diet. And then you need to consider more aggressive intervention at the first signs of any fracturing. And it doesn't matter what the bone density measurement is. Now, that's a bit of an unpopular opinion, but I feel comfortable justifying it. The only then question is, how hard do you go looking for fractures that nobody knew about? And there is a recommendation in the osteoporosis pediatric community to do routine lateral spine films, because the most likely place for a fracture to hide out unknown is in the vertebral column. So obtaining lateral spine films every few years is going to help you identify very early stages of osteoporosis. And the move in the community now is to intervene earlier at the first signs of any fracture, not necessarily waiting for an over clinically relevant fracture.
And what do those interventions look like?
The standard intervention are a class of medications called bisphosphonates. These are related to the things you see advertised on TV, Fosamax, Boniva, etc. In pediatrics, we generally do this as an IV infusion because it can be done just twice a year. So it's quite simple.
How about for the adult population?
That's still the primary. In the adult population, bisphosphonates are still the primary medications that are used. There are now a series of other medications that can be used when bisphosphonates have kind of used up their value. There's other things that can be added afterwards, but they all come with significant complexities. These are not used in the pediatric population, and not that aggressively in the adult population unless people have used up the value of bisphosphonates.
Thank you.
I just wanted to make one comment, just
Yes.
because the vitamin D is so important to bone health. And in an SCN2A room, I imagine most of parents, your children may have to take seizure medicines. And one of the things about many seizure medicines is they just kind of increase the rate at which your body uses vitamin D and kind of churns through it. And so if your care team aren't already kind of trending and tracking your kid's vitamin D level, I'd say for me it's at least with annual labs. Other providers may have other practices, but kind of on a regular basis following the vitamin D level so that we can know whether your child needs a supplement of vitamin D to keep their vitamin D levels healthy and keep their bones healthy.
Great, thank you. A few more questions here. Does this panel have any recommendations for the loss of parent caregivers? We're getting older as our kids get older, and we're not going to live forever. Any thoughts? I can give my thoughts. I'm trying to take really good care of myself, but also make sure that I've got people around who understand Alex and his needs, and make sure he's provided for financially with the life insurance, so that he doesn't have to be taken care of by complete strangers someday.
I think that is, nobody wants, this is another one of those nobody wants to have to think about, but we're humans and things like this will happen. And I think viewing ourselves more as a team and not just as a team within our nuclear family has been something that we've had to think about and we've had to have discussion about. And, as you're doing all those planning things that adults have to do and looking at what's it going to look like financially after we're gone, or what's it going to look like in the care world after we're gone, having other people involved in these things now so that it's not oh goodness, something's happened and now so-and-so who you've never met or some cousin down the road who you saw when you were a kid is now going to be the people involved in your life. Having those people planned now when I still have the ability to, I hate to say have some control, but I do have some control of who would be those people that would surround him at that point to step in and make some of those decisions, and to be able to set things up like that.
Yeah.
At this point, before it becomes a necessity because something has happened.
Yeah, I will say also one thing we've done, and probably you all have too, is make sure you have a will and/or trust, and make sure you've got several layers of, all the people in my generation, we may all be gone at the same time. So, and I don't want my other son to be the only one that, like you said, try to build a community. It's difficult, but it's really important to think about it in advance. I would agree.
I've talked to a lot of families who may not want to look at some of that outside help, like waivers can supply and things like that. But it's a different conversation to have with your adult children whenever I need you to help make some of the decisions to make sure he has a good waiver provider, to make sure things are set up in the way that we want things to be taken care of, and that all the daily care doesn't fall on her.
Mm-hmm.
I just want to add, because like what you were just saying, I have a lot of friends who are my age that if they were to, if I were to predecease them, they're willing to help out with whatever. And my niece is the plan for her. But things could change with her, right? So even now, I encourage you to contact your agencies and maybe go look at the different options, whether it's group homes, whether it's they have, foster homes for the medically fragile. Go look at what some of these things are so that it will take some of the fear out of it. Long before you're ready to have to think about it or need it, but at least it takes that sting and that fear out of it. And you can start, it just opens the horizon of what you might think about when you're trying to make those plans.
That's great. Thank you so much. Okay. Aside from thinkcollege.edu, what other resources are there for colleges that have robust disability support services? Guessing Renee is going to answer that one.
It's me again. There are lots of colleges around the country that offer post-high school planning and post-high school programs. And some of the things that I always tell families to look into, depending upon your child and depending upon the need and what your child's plan is, make sure as you visit the different schools, and there may be different places, different agencies within a particular college, if you are looking at a degree-seeking program, make sure that's what they offer. There are a lot of programs nationwide that aren't degree-seeking, but are some really cool programs within universities. But I have found families who they get into one and they're so excited, then they realize it's not a degree-seeking program. So if that's what you're looking for, make sure you have those discussions ahead of time. I've talked to a lot of universities that have programs within their colleges that have different requirements. There are many that for people that they're going to serve that have an IDD diagnosis, they must be their own guardian. I've talked to a lot of colleges, and then the families get a little bit nervous because they've already got guardianship, and so then they're having to kind of back plan a little bit. I've got some good research. I mean, I'll get those to Jennifer. She can get those on the website too. Of national clearinghouses that show all the colleges that have different programs and which programs within each college offer different planning. Is it a program where you're going to learn life skills and have some really cool experiences and live on campus and do things like that? Or is it a program that's going to offer support for an individual who is actually degree seeking there in order to make sure they have the accommodations they need for their best educational experience?
Great. Thank you. And then call Renee. We still have time if there are more questions. I only have one more left up here, but maybe some people up here have questions. This is a difficult one to answer, but maybe spark a good discussion. What states have the best quality of life for the adult warriors to access care and resources? Left them speechless. Is anyone out there in a state they consider a really great place?
I mean, you're in one. No, I was going to say that, America's a fantastic country, right? And we have so much wonderful diversity when you really look across the country at how we work, right? Like how the culture is, what the cost of living is, what the available jobs are for families. There's great diversity in our country. I think, though, one theme, if I think about what we've talked a lot about Medicaid and Medicaid waivers today. And I think one thing that might make a state better for young adults with disabilities is a solid Medicaid program and that state's commitment to funding its Medicaid program. So for me, if I were looking around the country and maybe thinking about moving or something like that, I would be ensuring that I'm moving to a place where it seems like the momentum or the commitment in the state for Medicaid supports is strong. That's all I'll say.
And I was just going to add to that. I've only lived in California, but we don't have the wait lists. And so when I looked at the Medicaid waiver, because we do have high taxes and high cost of living, and I looked at where would we like to live, honestly, we'd be on wait lists. We'd, just be starting completely over. And so for where we're at, California really is the best fit for us, but I think it's different for everyone.
And that's something that I have conversation with families a lot and my first sentence is waivers don't cross state lines. That's something that a lot of families don't understand, and we're from Arkansas, Walmart's in Arkansas, so we get a lot of families that move to Arkansas for Walmart. Walmart just closed down there, you can work from home, so there's a whole lot of families now moving. And they're in places like California and places that they may have received high levels of support. They didn't have a wait list, or they've made it through that state's wait list, and they're about to move to a state that right now the wait list is about 3 years. When Carson got on waiver, we were on the wait list for 10. And so I always tell families that SSI can typically, it's a kind of a pain, but it's a movable Medicaid. You'll close it in the previous state, you open it in the new state. Waivers won't. TEFRA is a waiver. Some states have different rules for TEFRA. Some states do not have TEFRA. If you're in a state that has a TEFRA program for your child who is under 18, that's something to think about. If you're leaving that state to move to a state that doesn't offer that type of program and you've had Medicaid for your child their whole life, you may be moving to a place that doesn't even have that as a choice, depending on your household income. But that move piece is a big deal. If you're thinking of moving, if you're wanting to move, if your husband or your wife or somebody just got a call that said we're transferring you to Bentonville, Arkansas tomorrow, reach out to people in those states. There are people there. The agency I work for, I talk to people every day. That's kind of what I do. In one of my roles there is just helping families navigate what's there and who do you call. Because if you don't know who to call, even if the best supports are available in that state, you don't have them. They're not available to you if you're not sure which phone number to call.
And to put in a plug for our Facebook group, I know that question has come up, and it's very helpful to share that kind of information. Maybe we can make it a little more formal at some point where we have people kind of list their experiences in different states and that someone could go look at if they're thinking about moving. Any more questions from the audience? Here, let me give you a microphone.
I'm going to ask the embarrassing boy question. Sorry, Renee. As our boys enter puberty, they want to touch themselves, and I have some questions about that. And then also questions, Josiah is also a ladies' man. I don't know if any of you have met his pigeon this week, but he's real excited to... How do we navigate potentially sexual relationships when they have sensory issues and they're not going to wrap it up? So questions about basically masturbation and sex, and I'm really sorry for those that don't want to hear these, but they're really important, so I've got to ask it. Sorry.
Yeah, I was going to say, I think there's a two-part answer to that. One, sometimes the touching yourself is not just boys. It is, everybody does that. That is something that as a parent, teaching where it's appropriate was our number one thing, when you can do this, because guess what? You're not going to stop it. It's the where that happens that matters. There's a rule at our house is if the door is closed, you knock, and there are things Mama doesn't want to see. He'll tell you, he goes, yeah, she says that all the time. But if his door's closed, it's his door. That's a piece of that safety thing that we really had lots of conversation about, because if they're not taught where it's safe to do it, it's safe to do it in front of anybody. And so having those rules of the bathroom with the door closed, your bedroom with the door closed. And, that do it in private. Private's a big answer because my living room is private. However, I'm there, Matt's there, Kendra's sometimes there, Mimi can come over. That's not private. A bedroom with the door closed is private. We have a door hanger that says, please knock. And if that's up, Mom ain't there. And so there's just a lot of things of having those conversations of where it's appropriate. And I think that's for everybody. And something that if you don't teach, and this is something I harp a lot, if you don't teach it to somebody, it's not their fault for doing it wrong. You have to make that piece of the conversation happen because you're the parent, and there's a lot of things that I look at that I go, oh my gosh, I can't believe this just happened. And then I look back and go, it happened because I didn't teach it differently. And so to kind of circle that back and have those kind of conversations are really hard. And sometimes having the conversation of what's the motivation, and if having those conversations about safe sexual activity, that's a conversation that has to be had. And I will bounce back to my favorite Vanderbilt Kennedy Center Healthy Bodies curriculum, because there's a lot of that in there and a lot of conversation about how do you start that conversation? Because I had conversations like that with my daughter, and I had conversations that looked and sounded differently with Carson, but we still had to have those conversations because at some point I didn't want him to think it's okay to talk to people in bathrooms, to have other people see things they shouldn't be seeing. And as the little people pleaser boy he is, if somebody asked and he didn't know he could say no, he would say yes. And so really having those tough conversations, Rachel, email me and I'll send you that whole set. If y'all are all welcome to email me, and I'll send you the whole set too. But that was an easy place for us to start because it gave me, because I needed the script.
I have an addendum to that. You know, you can have a conversation with your children. What about the children that may be having these issues where you can't actually have a conversation with them? Maybe that's a question for the doctors. I'm not sure.
Yeah, I'd say the self-stimulatory behaviors, those may still be present, right? And I think similarly, we can't stop them. There's, you know, and we shouldn't, maybe.
The more you try, the more they're going to do it, is what I've found.
And so really it's location, 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 you know, just trying to make time and space where it is okay. And then I think the second part of what you're alluding to is like, how do we ensure personal safety to a young adult who has intellectual disability and may be taken advantage of or abused? Mm-hmm. And I think that is a hard question to answer because really it requires the systems, the locations, the school, the day program, the transportation, every place where your child may be. It requires you to know them. Mm-hmm. And to, I think the biggest tenet that I would say ensures safety is always dual responsibility. So two team member changes, you know, that there's always at least two people who are working together to take care of your child when they're at a day program. Something is a great screening question to ask as you're touring or getting to know the place. Like, do you guys have a setup where there's always at least two grown-ups working together? And if their answer is, you know, no, sometimes they just have to go by themselves and do bathroom stuff, you might say, well, is there a way to make that not be such? Because it would make me feel safer. And you're right to ask that question and sort of try to work toward that as a goal, I think, for safety.
It does come back to that safety piece of it.
Any other audience questions or any panelists? Do you all have any questions for each other? All right. Well, all this information will be available on the website, and feel free to come and talk to us afterwards if you didn't want to ask your question publicly. And we're going to let you out, look, 6 minutes early for the next session. All right. Thank you, everyone.